Hola, ¿cómo estás? Thank you so much for the invitation to come to Mexico and share some of the experience from north of the border. The talk is about drug-induced endoscopy and the role of drug-induced endoscopy in sleep apnea. Just so I get a sense of the audience, how many of you actually do perform drug-induced sleep endoscopy in your practice, and how common is it here? Wow. Okay, so only a few people. Okay, so anyway, so I guess let's talk about drug-induced sleep endoscopy. So when we talk about the surgical treatment of sleep apnea, the goal is to address the targeted area of airway obstruction in order to improve patency of the airway and improve breathing during sleep. So the idea is that the reason why surgical procedures and treatments for sleep apnea do not succeed is because we are not addressing the proper airway sites. And so failure to identify the sites of obstruction is the principal factor in poor results of surgical and non-surgical treatment. So in our office, we usually look at the patient's airway, we do the physical exam, we all have laryngoscopes, and we look at the scope in the office and when patients are awake, and you can see that this patient has, kind of unremarkable, I guess, airway, a lot of left reflux probably. Epiglottis looks slightly retroflex, but otherwise you can't really appreciate what happens during sleep. So this is the same patient with drug-induced sleep endoscopy. And you can see that there's a lot of lateral collapse. There's some basic lung contribution to the air obstruction, but look what happens to the epiglottis. Here you can actually see that the main source of snoring in this patient is not really the vibration of the palate or the tonsils, but more of the epiglottis. And this is something that you can't really predict unless you actually look at the airway during sleep. And this one, you can actually see that how the epiglottis kind of creates almost like the obstruction, the main source of obstruction, kind of a trapdoor epiglottis. So that's why when you're looking at a patient's airway when they're awake, it's not the same as when they're asleep. So you can't really get the appreciation of what's really happening. So there's discrepancy between obstruction sites during sleep and when patients are awake. So that idea has been floating around for a while. And so they tried to see if we could introduce fiber optic scope, endoscope when people are asleep. But again, how many of you would be able to tolerate something through your nose when you're actually sleeping without waking up? I don't think that's going to happen. So the concept of drug-induced sleep endoscopy was introduced in 1991. And that's when they did sleep nasal endoscopy under sedation with continuous ventilation. Then it was renamed into drug-induced sleep endoscopy, DISE. That's commonly what the term is being used nowadays. So there are different ways to perform drug-induced sleep endoscopy, but most commonly, propofol is the preferred way to sedate the patients during sleep because it has very short half-life and has very minimal respiratory depression. Like if you think about propofol, right, if you use that and then patients wake up like nothing happens. So you really don't have a long recovery period, and patients, most of them can go back to their daily activities, and your surgical sleep or endoscopy sleep really has no issues with with them obstructing and recovering them afterwards. So the procedure again usually needs to be done in the controlled settings, either in endoscopy suite or in operating room type of setting, because one, we're operating with taking care of patients who have sleep apnea, and two, we're using medications that they're usually normal, a lot of times used in general anesthesia. So it has to be in a controlled environment. You don't want to just do it in the office and be covered by swishing with propofol. We usually do have anesthesiologists in a room, and you have to be able to manage the airway in case there is a laryngospasm, in case there is an airway obstruction. Things can happen. So you have to be truly prepared to stabilize the patient and manage them. But once you actually have patients sedated, procedure doesn't take so long. It depends what you're trying to accomplish, because there's a lot of things you can get from doing this procedure. But again, if you just want to look at the airway and get appreciation of what happens during sleep, about like 10-15 minutes of sedation, sometimes maybe more if you really want to be thorough. But the evaluation stage usually doesn't take too long. So again, the goal is to mimic the natural sleep, not necessarily give patient a general anesthesia. So if you're trying to sedate, so it's a little bit of an art of anesthesiologist who's assisting you. You're trying to kind of administer enough sedation that patients start to sort of breathe, kind of fall asleep, and you can elucidate what's really happening during sleep. But then you don't want to give them too much anesthesia to get them under general anesthesia, so that suddenly they are basically developing central apneas, and sedation is like going too deep, and you just don't really have a good understanding of what really happens during sleep. So the key is to get to the correct sedation level when patients actually spontaneously breathing. They're not really arousable to the verbal stimuli, but you can actually introduce the scope and look at the airway, and then you can start to see, like, when they're having witness apneas, starting to saturate with those apneas. But then again, if they're more central apneas that are induced by sedation, and also increase of sedation can on its own induce a lot of airway collapse. That might not necessarily be what's happening to the patient, but that actually could be also drug-induced airway collapse. So there's different ways of looking how the airway obstructs, and there's different grading scales that have been proposed, but this is the one that I use, and I think this is the one that's being used by a lot of people across the world. And it's a Vogt classification system, and Vogt stands basically for V, velopharynx, or oropharynx, T, tunnel base, and epiglottis. And this is a little bit of a subjective way of looking at the airway, because it's really dependent on the person who is performing it. And what you're trying to see is, like, well, you kind of look at the airway and you see, like, well, how much obstruction is happening. Is it no partial obstruction or complete obstruction? And then the direction of the obstruction, whether it's anterior, posterior, lateral, or concentric. So here are some of the examples of what we can observe. So if we start with the velopharynx, here's the airway. And you can see that there's a complete anterior-posterior obstruction of the patient during sleep. To compare it to like concentric collapse, so this is actually more of has a more of a sphincter-like appearance, and this is what you would observe with velopharynx when patients have concentric obstruction. And you can see that there is completely different direction of the airway. So this is oropharynx, right? And so here you can see the uvula, you can see the vibration of the palate. But as the patient gets a little bit deeper sleep, you can see that those tonsil hypertrophy, like large tonsils, they're coming closer and closer and closer together, and then suddenly you need to appreciate that definitely that's the main source of obstruction that has complete lateral obstruction of the airway now due to tonsil hypertrophy. And you can see how this patient can definitely benefit from a tonsillectomy, and if there's any question in your mind, like, this is a good candidate for a tonsillar surgery, and it might be even curable by that. So here's the base of tongue, and you can see that bulky base of tongue that just collapses posteriorly and pushes against the epiglottis and narrows the airway. Here's an example of the lingual tonsils. Right, so this is, you can see that the base of tongue actually ends right, okay. The base of tongue ends right here, and all of this is the lingual tonsils, right? And those are the ones that contribute to most of the airway obstruction and pushing against the epiglottis. And you can appreciate how this tissue reduction can potentially solve the airway obstruction. And this is another video of lingual tonsils. So these are lingual tonsils, but they just have such a different appearance. And you can see how those lingual tonsils kind of laterally squeeze the epiglottis and create significant airway obstruction. And mind you, this patient actually actually had palatal tonsils removed before, and he still has all of this tonsillar tissue. And what I find sometimes when you tell patients that they have lingual tonsils and the lingual tonsils are contributing to their airway obstruction, their first comment is like, but I already have my tonsils out. And you're like, well, there's different kinds of tonsils too. So anyway. So this is again like a picture of the state of the epiglottis. As I said, the trapdoor epiglottis that's blocking the airway, and you can see if you can potentially bring, do a epiglotopexy and bring the epiglottis closer to the base of tongue, or put like sutures to secure the epiglottis to prevent from flopping posteriorly. You can actually improve the airway obstruction. And then this is more of a omega-shaped epiglottis. Again, this is an example of how like epiglottis could be also, the shape of epiglottis can be contributing to the airway. This is with the jaw cleft, and then when you relax the jaw, the epiglottis on its own kind of like collapses and kind of almost, it's almost concentric collapse. Definitely lateral collapse, but if you think that the epiglottis cannot concentrically collapse, well, here's the example. So once the acoustic endoscopy was introduced, then we started looking, well, what kind of information can we get from it? And so this is a study that's been published a few years ago. They looked at 1,249 patients, and they underwent drug-assisted endoscopy and also polysomnography. And they basically tried to sort of associate the findings between severity of sleep apnea and findings in drug-assisted endoscopy. I think that was actually a very interesting study. So it did give us a perspective, like, what is really happening to people? Like, kind of categorized, like, well, what are we addressing? And so what they found that palatal collapse is probably the most commonly seen collapse in people with sleep apnea. And then palatal and base of tongue together are most common multi-level sites of obstruction. So then they were looking at the correlation between different physiologic parameters. And so what they were looking at, well, what happens to people as their BMI increases, right? And you can see that with the increase in BMI, your palatal collapse and oropharyngeal collapse presence actually becomes more prevalent as opposed to base of tongue. You can see that people who have predominantly base of tongue obstruction during sleep are people who are lower weight, not necessarily with a higher weight. So the increase in BMI is more associated with palatal oropharyngeal obstructions. Then we're looking at the severity of sleep apnea, and what we found that people with more severe sleep apnea are more likely to have hypopharyngeal problems versus base of tongue or versus palatal obstruction. And as you know, hypopharynx is usually a really difficult area to address surgically. As surgeons, for us, hypopharynx is really an issue. And you can see, if you have patients with severe sleep apnea, that's the problem that you most likely will have to deal with, and you have to be prepared for that. So when they talk about the pattern of airway collapse, they also looked at what type of patterns are more prevalent in each level, right? So for the palate, for example, they found that concentric collapse is more common. Again, I'm not exactly sure how accurate some of that could be. This could be extrapolated to every single group of patients, because if you think about BMI, correlation BMI impact of the palatal collapse, people who have higher BMIs are more likely to have concentric collapse versus people with lower BMIs. So I think if we talk about people with the lower BMIs, in those patients, I find that about 20% of those patients have concentric collapse. The majority of them have anterior posterior collapse. But I guess in this case, they probably used the full population. They didn't really break it down in terms of BMIs and not looking at the nature of collapse. So if you take a population as a whole, which is BMIs from, 25 to let's say 50 or whatever they use. So in those patients, if the population as a whole, I guess concentric collapse will be more prevalent. And then oropharynx, that's mostly commonly lateral collapse, and in terms of the tongue, and you will probably see more anterior posterior collapse in these patients, which makes sense. And then as far as hypopharynx is concerned, again, lateral collapse is a bit more prevalent in patients with sleep apnea. So then they started looking at, well, so what happens during surgery? How do you use like drug-induced endoscopy to predict the outcomes of the surgical procedure. So they looked at, so there's a study that they looked at 49 patients, they did drug-induced endoscopy, they did upper airway surgery, and then did as well as sonographic evaluation to see what happens. And so what they found that there were responders, non-responders, about the same number of people responded to surgery, so 50% of patients do respond to surgery, as we all know. And what they found that there is a correlation between having a circumferential collapse at the velopharynx and also having more anterior posterior collapse at the tongue base and epiglottis. Those were associated with non-responders, versus responders were less likely to have those type of obstruction. Then there's another study that looked at, again, surgical outcomes in association with DICE. Again, they had patients who were responders, non-responders, about the same number of patients. And they found that, again, the failure group were more likely to have vasospasm obstruction and also obstruction on the velopharynx. So similar results. And what the other thing what they found that people who responded to surgical treatments were more likely to have the palatal upper airway side of palatal obstruction. So site of the having presence of the palatal obstruction predominantly was associated with higher success rate. Personally, for me, drug-induced endoscopy has become more useful when I started doing neurosimulation, because then that's something that they've introduced, and what they found is people who have concentric collapse are less likely to improve to neurostimulation as opposed to patients with anterior posterior collapse. So, so the company who, that specifically the Inspire that's now FDA approved and available in the United States requires us to actually have every single patient undergo drug-induced endoscopy to specifically rule out that concentric collapse at the velopharynx because they are not good candidates for neurostimulation. So meta-analysis that was published in 2016, we looked at like, well, what does DICE do for surgical planning in patients? What do we do with it? And they found that about 50% of cases, people change their plan when it comes to surgery when they actually evaluate the drug-induced endoscopy and evaluate the airway. And most of the time, the changes were associated with hypopharyngeal and laryngeal obstruction. And as you said, so earlier, that's something that you cannot easily appreciate on a wake evaluation. So then, Mark Blumen and colleagues in France, what they did, they actually decided to say, well, how useful is drug-induced endoscopy? And what they did, they planned surgery. Okay, so they talked to the patient, planned the surgery, and then before performing the surgery, they did drug-induced endoscopy. They still proceeded with the surgery that was originally planned, and then they looked at what happened to the patient. And so what they found that regardless whether they treated both sides of obstruction or like no sides of obstruction, basically there's not much difference between the success and failure group. So they concluded that sometimes you don't really need to operate on all the obstruction sides because if you operating on more sides doesn't always improve surgical outcomes. So in some cases, drug-induced endoscopy might actually estimate the anatomic contribution to sleep apnea, might actually lead to some unnecessary surgery. So that's why controversy of drug-induced endoscopy still is out there. So this is an example of what else we can do with drug-induced endoscopy. So this is a patient who has severe sleep apnea, and this patient actually is mouth breathing during sleep. And this is what happens to the base of tongue and epiglottis with just a simple mouth closure. Not a jaw thrust, nothing. It's just a little bit of a mouth closure. And that was kind of like, very drastic. So I started looking at that a lot more in patients, like, when they are under sedation and they have a pretty significant base of tongue collapse and they're mouth breathing, they're opening their mouth during sleep. You close their mouth and the airway completely improves. I mean, this is like night and day. And so, again, that basically demonstrates how important is nasal breathing during sleep as opposed to mouth breathing. And this patient, actually, I asked him, do you want to try and use a chin strap? Well, no, she hasn't come back yet. The next patient is a patient who has severe sleep apnea, has tonsil hypertrophy, and was very hesitant about getting his tonsils out. And so anyway, so this is a drug-induced endoscopy, so he wanted to see what happens during sleep. So you can see how his tonsils really collapsing and obstructing the airway. He also went to see a dentist. His dentist made him an oral implant. And again, this is the same patient doing the same procedure, just with an oral implant. And you can see that even with pretty significant tonsil hypertrophy, dental appliance can still stabilize the airway. It doesn't necessarily need to move the tongue forward, doesn't necessarily need to change anything. All of this is just stabilizing the airway enough to prevent tonsils from collapsing. This patient ended up getting tonsils out anyway because he said that sometimes he goes out, he's like 30-something-year-old, he goes out, he forgets to put the oral plants in, so he wanted to just be sure. So, anyway. So drug-induced endoscopy is a useful tool. It's not perfect, but this is the best we have when it comes to looking at the sites of the airway obstruction. You can use that in different ways. It should be helpful to your practice. You can perform it when you're looking for alternatives to CPAP treatment, and looking for types of how can you improve patients' response to either CPAP or oral appliance, whether there's a positional component, how positional therapy can improve patients' airway, because when you do drug-induced endoscopy, you don't have to always have them in the back. You can also turn them around, you can change their position of their head to further evaluate the therapy. So this is a good way to basically assess, well, is this a patient who can benefit from a single modality or multimodality, multi-level, or combined therapy as well. It also helps us understand why people are failing either surgical or non-surgical methods. And if you have patients who are already failing the treatment, you can sort of further identify the sites of the problem and proceed with further treatment.